Hello everyone, welcome back to the Farre Series. I'm Dr. Patil and we will be continuing our medicine topics. So today in next 1 hour, we will be covering some of the important questions from infectious diseases. For the theory exam, there are 5 important infections which includes HIV, tuberculosis, enteric fever, dengue and malaria. Just give me a thumbs up if I am visible to you. Tuberculosis, enteric fever. Okay. So out of these three, that is HIV, TB, and enteric fever, I will address through the class. And the notes of dengue and malaria is already uploaded on the PW MedEd app under the Farre section. So both the questions you can cover from there. Infectious diseases, though inside the books it's a very vast section. In your theory papers, generally we get one major question from this and not many minor questions. So restrict your time that you spend on the infectious diseases, and I would rather suggest that spend the time on the endocrinology because a larger number of questions are going to come from endocrine, right? So today I will cover these three infections: HIV, TB, and enteric fever. We'll start with the HIV itself. Okay, so the question on HIV generally goes like this. Describe the clinical features, diagnosis, and management of HIV. Write a short note on opportunistic infections and iris, right? So if it is a 10-mark question, what will be the distribution of marks? So if it is a 10-mark question, the clinical features will take 2 marks, the diagnosis will take 2 marks, the management of HIV will take 2 marks, so that is 6 marks. Okay, and 3 marks for the listing of opportunistic infections, and 1 to 2 marks for immune reconstitution inflammatory syndrome or IRIS. Sometimes they can just ask you to write a short note on opportunistic infections for 5 marks or the IRIS for 3 marks if your university has 3 marks questions, right? So we'll try to address so that even if they split this question, you should be able to answer it. So we'll begin with the introduction to the organism. What is HIV? HIV is a virus, right? What kind of virus? It is a RNA virus. HIV is a RNA virus belonging to Retroviridae, right? It belongs to Retroviridae. There are 2 types of HIV viruses, the type 1 and type 2. Points you need to write here is type 1 is more common, type 2 is less common, and type 2 is characterized by slow progression. Slow progression. So if someone is infected with HIV, he progresses much slower to develop AIDS if it is type 2 in comparison to type 1, right? So type 2 has slow progression. This is something that examiner will be looking for if you're writing type 1 and type 2. Mention that type 2 has slow progression and it is less common in comparison to type 1. Okay. Now, next, after that, we have given the introduction to the organism. Now we will talk about the route of transmission. So what is the route of transmission? The route of transmission is sexual or parenteral. Parenteral. So when we mention parenteral, you can mention needle stick injury and blood transfusion But what is the most common mode of transmission? The most common mode of transmission is sexual, but that doesn't mean the sexual mode of transmission carries the highest risk. The most common mode of transmission is sexual, but the strongest risk or the highest risk of acquiring HIV infection comes from the blood transfusion, right? Sexual is the most common mode of HIV transmission. Most common mode of HIV transmission is sexual. Okay. Now the risk of HIV transmission is highest with the blood transfusion, followed by parent to child, that is mother to child transmission. Mainly this happens during the delivery. After that, the next highest risk is the sexual route, that to receptive anal intercourse. That's why HIV is more common among the gay people. Followed by IV drug abuse, followed by receptive vaginal intercourse. Okay. One more point, if you want to get a brownie score from your examiner, you should mention that the risk of transmission following needle stick injury, risk of transmission after needle stick injury is very negligible. Needle stick injury is 0.3%. 0.3%. So it is negligible. Okay, clear? Now, what clinical features a patient with HIV is expected to present with? Now we know that majority of the HIV patients may not be having any of the symptoms, and they get recognized when we screen them for HIV, right? When they go to donate blood or when they're undergoing a surgery, and as a pre-workup, pre-surgical workup, the doctor asks from HIV, or they're hospitalized, or their employment demands that they should get the HIV test done, and then it is identified. But at least some patients do present with clinical symptoms early in the course of the illness. So we will understand the natural course of HIV infection. Natural course of HIV infection, how HIV infection progresses. So once there is an HIV infection, whatever is the route of acquisition, once there is an HIV infection, around 50% of the people develop something called as acute HIV syndrome. Around 50%, not everyone. So if there are like 100 people infected with HIV, maybe around 50. Approximately 50% of the people develop what we call as acute HIV syndrome, and 50% do not develop any acute infection symptoms. They just get infected, and the HIV keeps replicating in their lymphoid organs for a very long period before the clinical features become evident. But half of the people, as soon as they got infected, within 2 to 3 weeks of infection, they start developing a rash and fever. This is what we call as acute HIV syndrome. This acute HIV syndrome presents with clinical features very similar to infectious mononucleosis. So what symptoms we get in infectious mononucleosis? Fever, rash, and third, lymphadenopathy. Fever, rash, and lymphadenopathy. So these are the three symptoms that we can usually expect for half of the patients infected with HIV, usually 2 to 3 weeks after the infection. Okay. Now the remaining half, they get infected, they do not develop any acute infection, they just become infected with HIV, and the HIV keeps replicating in the gut associated lymphoid tissue. Okay. So as it goes on replicating, the CD4 cell count goes on depleting, and the HIV viral level goes on increasing. At some critical low CD4 cell count, the patient will start developing opportunistic infections, and then he will end up developing what we call as AIDS. Okay. Now, how will I diagnose someone when they present with acute HIV syndrome? Because similar presentation is seen in infectious mononucleosis and other various viral infections, right? So usually if a patient presents with acute HIV syndrome, at that point of time, the CD4 count will be going down. But this point of time during the acute HIV infection, body may not be producing antibodies yet, or antibodies might not have reached the detectable level. So for acute HIV syndrome, the standard antibody based tests, which are testing for the antibodies against HIV-1 or HIV-2, are generally not detectable or positive. So only the HIV P24 assay will be positive, or the HIV PCR can be positive. So if I have to diagnose HIV during the acute HIV syndrome, it can be diagnosed by P24 positivity or the PCR detecting the HIV virus. Okay, there will be no antibodies during this period. Okay, clear? Remaining half, they're directly entering the chronic phase. So even those who had acute HIV syndrome, once the antibodies start appearing, right, the antibodies against whatever is the infecting organism, HIV-1 or HIV-2, they will try to neutralize the viruses as much as possible. So the CD4 count will start rising again. So during acute phase, there is drop in CD4 count. But once the antibodies come and keep check on the virus, the CD4 count will start improving, right? So all these symptoms will disappear. And then patient enters a phase called as chronic phase. Half of the patients have entered this directly. So during this chronic phase, what happens? CD4 count is normalized, and then Shivam, I'm good. Normalized, and then progressively declines. Okay. Second, most of these patients in the chronic phase are going to be asymptomatic. They are going to be asymptomatic. As a doctor, I can only suspect the possibility of HIV in them based on the history. History is that, okay, there is promiscuous behavior or high risk sexual contacts, right? Or certain professions which puts them at such promiscuous risk of such promiscuous behavior. Otherwise, they may not be symptomatic, but there are some clues on examination. In the chronic HIV phase, majority of them have generalized lymphadenopathy. So, on routine examination, if you identify that patient has generalized lymphadenopathy, may be suggestive of HIV and it calls for screening for HIV. But during this phase, as I mentioned, there is progressive decline in the CD4 count. As the viruses go on replicating, the CD4 count goes on decreasing. And when the CD4 count drops below 200, then the opportunistic infections start coming in, and then we will call it as AIDS. So what is AIDS? AIDS is not equal to HIV. AIDS is HIV with low CD4 count resulting in AIDS defining illnesses, which are nothing but major opportunistic infections. So in the AIDS stage, what do I get? In the AIDS stage, I have major opportunistic infections. Major opportunistic infections. So to summarize, what is it? You have HIV infection. Okay. Half of the patients will develop acute HIV syndrome. Other half do not develop. But both of them will become chronic phase HIV patients, during which the CD4 count goes down and the HIV viral load increases. And we will reach a point where CD4 count is very low, viral load is very high. That puts us at the risk of opportunistic infection. At that point of time, we will start calling it as AIDS once patient has developed major opportunistic infections. Those major opportunistic infections are also called as AIDS defining illnesses. Okay. So that is about the clinical features of HIV. Now, what are these opportunistic infections that we are talking about? Opportunistic infections are relatable to the CD4 count. So once the CD4 count is less than 500, there is very high risk of developing tuberculosis. In fact, tuberculosis is the most common opportunistic infection in HIV patients. It is the most common opportunistic infection in HIV patients. So that is why all patients with HIV should be screened for the presence of latent TB, and for the eradication of the latent TB, they should be given INICET prophylaxis. Okay. During this period, patients can also develop bacterial pneumonia, herpes zoster, candidiasis, oropharyngeal, not esophageal. Right? I want you to remember this point very precisely. When CD4 count is less than 500, we tend to get oropharyngeal candidiasis, oral candidiasis, or pharyngeal candidiasis. Okay. Then non-typhoid salmonellosis, Kaposi sarcoma, and non-Hodgkin's lymphoma risk is increased when the CD4 count is less than 500. But when it is less than 200, we start seeing more major opportunistic infections which are not seen in usually immunocompetent individuals. Can an immunocompetent individual get tuberculosis? Yes, very common. Can an immunocompetent normal individual get bacterial pneumonia? Yes. Herpes zoster? Yes. Right. Non-typhoid salmonellosis? Yes. But can a normal healthy individual develop pneumocystis jirovecii pneumonia? No. Typically when someone is immunocompromised. So when it is less than 200, immunocompromised state is kicking in, and then we start seeing infections which are not routinely seen in healthy individuals. So pneumocystis jirovecii pneumonia is the most important opportunistic infection that you need to remember when CD4 count is less than 200. Right. Apart from that, chronic herpes simplex ulcer. Now comes the esophageal candidiasis. So oral and pharyngeal candidiasis when CD4 count is less than 500, but esophageal when it is less than 200. Okay. So in Isospora belli infection of the GIT producing diarrhea. And then we have HIV wasting syndrome. What is HIV wasting syndrome? It refers to unexplained weight loss in HIV patients. Unexplained weight loss in HIV patients. This can also be called as HIV cachexia. HIV cachexia. And then HIV also starts affecting the CNS functions, that is the HIV associated dementia, which in the past we used to call it as AIDS dementia complex. We no longer call it as AIDS dementia complex. We simply call it as HIV associated dementia. All of these are happening when the CD4 count is less than 200. When the CD4 count drops below 100, then we start getting the risk of infection with the Toxoplasma gondii, presenting as cerebral toxoplasmosis. Then cryptococcal meningitis, which had been the repeatedly asked MCQ for the NEET PG exam, which CD4 count puts someone at increased risk of cryptococcal meningitis, right? Then cerebral toxoplasmosis, cryptosporidiasis, and then disseminated MAC infection, that is Mycobacterium avium complex infections. So these are the ones I want you to remember when the CD4 count is less than 100, and when the CD4 count drops further down to less than 50, the MAC infection becomes even more common, the toxoplasmosis becomes even more common, and cytomegalovirus infection becomes even more common. All of these have started appearing when the count is less than 100, but higher prevalence when the count becomes less than 50, right? So majority of them which are listed under 200, they all come under what we call as AIDS defining illness. So let us say there is an HIV positive individual, CD4 count less than 200, and he developed a pneumocystis jirovecii infection. Then now we can say he has got AIDS, right? Similarly, I have a person with CD4 count less than 200, HIV positive, and he developed cerebral toxoplasmosis. So now he has AIDS. Clear? Okay. Now that we know the basics of HIV, those who have joined late, let me give you a quick summary. What is HIV? It is a chronic viral infection acquired through either sexual or parental route caused by human immunodeficiency virus. There are two types, type 1 and type 2. Both belong to Retroviridae family. They are RNA viruses. And the risk of transmission can happen sexual or through parental route. The risk of transmission is highest for blood transfusion, which is more than 97%, followed by mother to child transmission during labor, then the sexual route, that is anal route, then IV drug abuse, then vaginal sexual intercourse. So this is the risk of transmission. Risk of transmission because of needle stick injury is very minimal, which is 0.3%. Once someone gets infected with HIV, half of the patients develop signs and symptoms of acute infection. Half of them do not develop any signs and symptoms of acute infection. Those who develop signs and symptoms of acute infection, those patients are called as having acute HIV syndrome, which resembles like any other viral infection, most likely infectious mononucleosis, where patients will have fever, rash mainly on the upper part of the body, and generalized lymphadenopathy, okay, which subsides within few days to weeks, and then patient enters into chronic phase. In the chronic phase, progressively CD4 cell count goes on decreasing because HIV infects the CD4 cells, and when they use the CD4 cells to replicate inside the CD4 cells, they cause injury to the CD4 cell membrane. When they leave the cell, the replicated viruses, when they are released outside, they cause injury to the CD4 cell membrane, resulting in decline in the CD4 cell count. So in the chronic phase, progressively CD4 cell count goes on decreasing, and at one critical point, which is generally 200 or lesser, patients start getting opportunistic infections or other AIDS defining illnesses, and at that stage we call the patient as having AIDS. This is the clinical features of HIV, and we have listed the opportunistic infections that we get here. Now let us talk about the diagnosis of HIV. So for diagnosis, the screening test is going to be detection of the antibodies for HIV-1 and HIV-2, right? But can I screen the patient in the acute HIV syndrome stage or in the window period where the antibodies have not yet appeared, right? So for screening in window period, I cannot, because antibodies would not be formed during that period. So for window period, we can do the P24 assay or the HIV PCR, P24 assay or HIV PCR. And once the screening has shown that there is HIV positivity, because there is possibility of false positives, we need to go for a confirmatory test. The confirmatory test can be either HIV-1 or 2 antibody differentiation immunoassay or HIV RNA PCR, right? So today, most of us prefer to go ahead with HIV RNA PCR because it not only tells, not only confirms that there is HIV infection, it also quantifies the HIV RNA particles or the viral load in the blood. Clear? Okay. So once I have diagnosed, how will I manage a patient with HIV? All the patients of HIV should be given antiretroviral therapy or ART. Okay. Now, what are the indications for ART? So the indications for ART right now, currently, it is all HIV confirmed cases regardless of CD4 count. So once upon a time, it used to be like when the CD4 count is less than 200, we used to start the ART. Now we are not doing it anymore. Why? Because I just gave you the natural progression of the disease, right? HIV infection, then acute, chronic, and then AIDS. The rate of progression from infection to AIDS depends on two factors. What are those? Viral load and CD4 count, right? So as the viral load goes on increasing, CD4 count will go on decreasing, and the patient will head towards AIDS. So if we keep the viral load low, right, CD4 count will be automatically maintained higher, and the rate of progression from infection to AIDS becomes slowed down. So why start antiretroviral drugs once patient has reached the AIDS stage? Let us start it as soon as the infection is confirmed, so that I can slow down, delay, or completely obscure the chance of this patient progressing towards AIDS, right? So that's why it is now indicated for all patients. Once someone is detected as having HIV positive, confirmed case, we should be started on ART. Now, what is the currently recommended regimen? The currently recommended regimen can be remembered with the mnemonic TLD. TLD regimen. It's a 3-drug combination where T stands for TDF, which is tenofovir disoproxil fumarate. It is tenofovir. Okay, and then 3TC stands for lamivudine, and DTG stands for dolutegravir. So this combination, TLD regimen, is the current standard go-to regimen for most patients of HIV until and unless there is a contraindication or hypersensitivity reactions to one of these drugs. Okay. For whom we are giving it? We are giving it for all patients. So once I start them on ART, regularly I will monitor their CD4 count and the viral load. The goal is to keep the CD4 count higher than 200 and viral load undetectable, if not possible, as low as possible, so that the risk of progression to AIDS is significantly slowed down. Okay. For some unfortunate patients, if our drug therapy fails or if patient is not consistent with the drugs, they will land up at a point where the CD4 count is less than 200, which of course puts them at risk of opportunistic infections. At such stage, we might have to also start them on prophylactic treatment to slow down or reduce the risk of developing opportunistic infections. Okay. So when the CD4 count is less than 200, which organism commands the prophylaxis? Yes, it is the Pneumocystis jirovecii or Pneumocystis carinii infection. Okay. And when the CD4 count is less than 100, we also need to consider prophylaxis for the Toxoplasma gondii, because toxoplasmosis risk, as we mentioned earlier in the slide, it is higher. Okay. And once the CD4 count is less than 50, right, then MAC complex risk becomes higher, so we need to provide prophylaxis. Now, examiner expect me to write the agents that I will be using for prophylaxis, right? So for Pneumocystis jirovecii as well as toxoplasmosis, it is the cotrimoxazole, which will be used, that is combination of trimethoprim and sulfamethoxazole in double strength, will be used as the prophylactic agent for jirovecii as well as T. gondii. And the agent of choice for prophylaxis of MAC is going to be azithromycin. So if the CD4 count is below 200, we start them on cotrimoxazole BD, and once the CD4 count is less than 50, we also start them on azithromycin. Clear? Okay. So one more thing we did not address about the prophylaxis is that there is a standard recommendation that all patients of HIV should be screened for latent TB, and whoever is having latent TB should be given the treatment so that the latent TB is eradicated. Means, what is latent TB? You have TB organisms in your body, but they are not active, they are dormant. So you don't have an active tuberculosis going on, but you have TB organisms in your body, which is a common case for most Indians, right? Because there is so much of exposure to TB among Indians that many of us may be having the TB bacilli in our lungs. So we should be screened for the latent tuberculosis, because HIV means there is activation of tuberculosis. So this latent TB will become active TB. So they should be screened and given the INICET prophylaxis. In the context of India, almost every patient needs the prophylaxis for tuberculosis, right? So TB prophylaxis, what is the drug of choice? So for the TB prophylaxis in HIV individuals, we are primarily giving INH. We are giving INH for 6 months. Or we can also use rifampicin for 4 months. Rifampicin for 4 months. Indication for TB prophylaxis in HIV individuals. In India, according to NACO guidelines, all HIV positive patients who have completed 6 months of ART, completed 6 months of ART. So once I have diagnosed someone as having HIV, I start ART. But after 6 months, I will also give him 6 months of INH or 4 months of rifampicin, so that if there is latent TB, it is taken care of. We don't run behind investigating and identifying whether this individual is having latent TB or not. Right? So this is as per the National AIDS Control Organization guidelines. Okay. Now, what complications HIV can lead to apart from opportunistic infections? What complications HIV can lead to apart from opportunistic infections? Complications of HIV. So we have just discussed that HIV is associated with opportunistic infections. Beyond that, HIV increases the risk of Kaposi's sarcoma. Okay. Then there is overall increased risk of cancers, overall increased risk of cancers. HIV is also associated with increased risk of coronary artery disease or ischemic heart disease. And then HIV causes what is called as HIV associated dementia. HIV associated dementia. So collectively we can say that HIV is associated with increased mortality rate. So the risk of death of an individual infected with HIV is higher. But of course, in the era of more advanced and effective antiretroviral drugs, the mortality rate has significantly come down and all these complications have significantly reduced. So we started seeing all these complications, including the opportunistic infections, less and less frequently these days. And the average survival of an HIV positive individual has significantly increased over last few decades, right? Over last 2 or 3 decades, the people living their full lifetime with HIV infection has increased like anything. But just 25-30 years back, like in 90s, when someone is diagnosed with HIV, most of them used to die within few months to max few years. Nobody used to survive for a decade. So that is the advantage of modern medications. So in fact, today, if you ask me, sir, is it better to have an uncontrolled diabetes for 5 years, or is it better to have HIV for 5 years? I would probably vote for HIV for 5 years, because our medications can definitely do a remarkable difference. An uncontrolled diabetes will like wreak havoc on the metabolism. It will cause more organ damage probably than HIV patient who is very religiously following the ART medications. Okay, so this is about the HIV. Next, we will take up the tuberculosis. So the question goes like this: describe the clinical features, diagnosis, and management of tuberculosis. Elaborate on the terms latent TB infection or LTBI, MDR TB, and XDR TB. So if question is asked like this, it is usually for 10 marks. The question may also have another layer, like write a short note on the diagnosis and management of TB meningitis, or write a short note on abdominal tuberculosis, right? Or write a short note on pulmonary tuberculosis. So we should be able to address that. Okay. So if it is a 10-mark question, the clinical features will carry 2 marks or 3 marks depending on relative weightage given to the other questions, other parts. 2 marks for the diagnosis. Okay. Management will carry 3 marks, because in the management we have to mention the regimens. And then the terms like latent TB infection should be given 2 marks, MDR TB definition 1 mark, and XDR TB definition 1 or 2 marks. So that is roughly a 10-mark question. Okay. So what is tuberculosis? Tuberculosis is a chronic infection caused by what organism? By Mycobacterium tuberculosis, right? Mycobacterium tuberculosis. And what is its mode of spread? Mycobacterium tuberculosis primarily spreads through droplets, right? Mode of transmission is droplets. Thus, you can say it is the airborne route of spread. Airborne route of spread. Okay. Now, what are the risk factors for getting infected with HIV? Tuberculosis. Risk factors for TB infection. So, risk factors for TB infection include number one, low socioeconomic status, because all these airborne infections are typically more common in places where there is overcrowding, right, where lot many people are living in small houses and there is less open space outside your house. So in slum dwellers or people living in extremely crowded apartments is where respiratory infections spread more rapidly. So is tuberculosis, right? So low socioeconomic status, low socioeconomic status. Second, people with malnutrition is at increased risk of developing the TB infection. Third, even alcoholics are at higher risk of developing TB infections than people living in endemic areas, right? Whole India is endemic. So of course, Indians are at increased risk of developing tuberculosis in comparison to Western world, right? So in Western world, TB is a rare diagnosis. They will probably think rarely about TB when someone presents with some cough or hemoptysis. But in India, if someone presents with chronic cough, the first thing we are expected to think of is TB because we are endemic, just like India and other Southeast Asian countries and some African countries. We are endemic to TB. Okay. Now, what clinical features a patient with tuberculosis presents? So, TB predominantly causes, or because it is airborne transmission, it affects the respiratory system. So, the most commonly affected organ by tuberculosis infection is pulmonary, right? Pulmonary TB is the most common form of TB. Now, what symptoms a patient with pulmonary TB will present with? Patients of pulmonary TB generally present with subacute to chronic cough. They can present with subacute to chronic cough. They can have hemoptysis, that is expectoration or coughing out of blood. Okay. Then they can have shortness of breath or dyspnea. These are the usual symptoms that we expect in a patient with pulmonary TB, right? But apart from that, whether it is pulmonary or extrapulmonary, many patients of TB will have certain general symptoms. What are the general symptoms that I need to write in the exam? First thing is fever, and whenever you write about fever, you can mention that especially in the evenings or during the evening hours, especially in the evenings, or you can write evening rise of temperature bar fever. Okay. Second thing, patients can have night sweats, and the third thing, they can have weight loss. So in fact, in India, anyone who presents with unintentional weight loss, tuberculosis will always remain a differential diagnosis. In the today's world, we also consider HIV as a differential diagnosis for unintentional weight loss, and third is cancers. Right? So TB tops the list of differential diagnosis for unintentional weight loss. So these are the general symptoms that I will be mentioning. So general is fever, night sweats, and weight loss. The pulmonary TB specific symptoms is chronic or subacute cough, hemoptysis, and dyspnea. Okay. Apart from that, there can be extrapulmonary TB. Extrapulmonary TB is relatively less common than pulmonary TB because pulmonary is where we acquire. From here, it is the hematogenous spread or blood route spread to the other organs where the TB bacilli can multiply. Okay. So among the extrapulmonary TB, the lymph node TB is the most common. So this is the most common extrapulmonary TB, site of TB. Typically affects cervical lymph nodes where it presents as painless matted cervical lymphadenopathy, right? Cervical lymphadenopathy. These patients will generally have multiple lymph nodes enlarged, mainly in the cervical region. They are painless and they are matted. Matted means they are attached to each other. It appears like one larger mass with nodular surface, right? Then we can also have pleural TB. Pleural TB is different from pulmonary TB. Pulmonary TB, when I say, I am primarily referring to the lung parenchyma being affected, but pleura can also be affected. When there is pleural TB, patient can present with pleural effusion resulting in dyspnea and chest pain, right? Pleural effusion resulting in shortness of breath and chest pain. TB can also cause meningitis, as we know, right? So if TB causes meningitis, these patients can present with fever and neck stiffness. And when I do lumbar puncture, the CSF analysis is going to show, what is it going to show? It is going to show exudative picture, right? It is going to show exudative CSF picture. Okay. Now, if I do exudative CSF picture with lymphocytosis, so in the CSF, the lymphocytes will be significantly elevated in comparison to neutrophils. If it is pyogenic meningitis, it is neutrophilic predominance. Okay. Skeletal TB can cause osteomyelitis. TB is also one of the cause for osteomyelitis. Apart from that, it can affect the spine, where it can form a tubercular abscess. We call it as Pott's spine. So that is the skeletal tuberculosis. We can also have abdominal TB. Abdominal TB, two things I want you to mention. The first thing that I want you to mention in the abdominal TB is tuberculosis of the peritoneum causing the tubercular ascites, right? TB peritoneum causing tubercular ascites, right? That causes ascites. And then the tuberculosis can also affect the ileocecal region, ascites, and that can be ileocecal TB. So usually what happens is these patients who are infected with, like those who have pulmonary TB, when they cough out, they are coughing out the tubercle bacilli, right? The acid-fast bacilli. They may swallow it, and they're resistant to acid, so stomach acid will not be able to destroy it, and the swallowed sputum will eventually reach, and it spends sweet good time in the terminal ileum, where the bacilli can again invade into the terminal ileum, and then they can cause the tuberculosis infection there. So it can cause ileocecal TB, which may present with, right, it can present with ileocecal obstruction or perforation. It can present with ileocecal obstruction, because tuberculosis means there is a granulomatous infection. We form a granuloma, right? We form multiple granulomas. So there will be a tuberculoma formed, which can intrude and obstruct the ileocecal junction. So it can present with ileocecal obstruction, or if the granulomas are extensive, even perforation is a possibility, ileocecal perforation. Okay. Then we have something called as miliary TB. Okay. So what is this miliary TB? Miliary TB refers to disseminated TB presenting with multiple organ dysfunction. Okay, I'll repeat. So abdominal TB, right? So normally what happens is, most common site of TB infection is respiratory system, right? Lungs. So in the lungs, we will have a cavitary lesion, and then I will be coughing out the TB bacilli. I will be throwing the droplets. Someone who spends close time with me will also get infected. That is the airborne spread. But now, when I cough out the sputum, I need not always spit, right? We tend to swallow it. And the TB bacilli are resistant to acids for the digestion. So as I swallow the sputum, the TB bacilli may not be killed by the gastric acid. So through the sputum, the bacilli may eventually reach my ileocecal junction, because food spends reasonable amount of time in the ileocecal junction, and it's that because it's a narrow junction. The TB bacilli find sufficient time to infect that area, that is the ileocecal junction. So once they infect, body will try to contain the infection by sending macrophages and other cells to form a granuloma. So basically, what is granuloma? Granuloma is an active colony of immune cells trying to keep the infection under check, because it is not easy for our immune system to destroy the TB bacilli. So instead, what is better thing? keep the enemy restricted to that area, let him not spread. So how do we do that? By creating a colony of cells mainly comprising of macrophages, which will surround and keep those bacilli in check. This is what we call as a granuloma. So when too many granulomas form in a small region, right, like multiple granulomas, that whole region looks like a tumorous, right? That is what we call as tuberculoma. Tuberculoma is nothing but a swelling formed because of multiple tubercular granulomas. And because the ileocecal junction, right, let us say this is cecum and this is the ileum. This is ileocecal junction, which is a narrow space. And in that narrow space, if a granuloma forms, right, let us say this is the cecum and this is the ileum. If there is formation of granulomas or tuberculomas, it will obstruct or narrow down the ileocecal junction. So patients can now present with ileocecal obstruction. Or these granulomas, because it is inflammation, the tissue will be friable, somewhere it will rupture, and I can have perforation of the ileocecal junction. So those are manifestations of abdominal TB. Ascites because of peritoneal seeding, and obstruction or perforation because of the ileocecal TB. Then miliary TB is a more advanced, difficult to treat, high mortality state where the TB infection spreads to multiple organs through hematogenous route. Dissemination of the TB from the lungs or from other organs, from an extrapulmonary site, it spreads to multiple organs. And those organs which are now affected by the shower of TB bacilli will start losing function. So there will be multi-organ dysfunction. So miliary TB is associated with high mortality because of the multi-organ dysfunction. Okay, so this is about the clinical features of TB. So while writing the clinical features, what have we done? We have divided into general, pulmonary and extrapulmonary. Whether it is pulmonary or extrapulmonary, patients may have fever, night sweats and weight loss. That's why we have put them under general. Pulmonary primarily presents with respiratory symptoms. Extrapulmonary, depending on the affected organ, they are going to present with the symptoms, and those symptoms under those affected organ headings we are describing it. Okay. Yes, Dr. Prakash. Okay. Now, in this question, as we noticed, they have mentioned that we should be writing a short note or elaboration on the terms latent TB infection, MDR TB, and XDR TB, right? So let us try to address these terms as well. Okay. So we can put that under this heading of types of TB. Now, what is latent TB infection? Latent means there is no active TB, but you have the TB bacilli in your body. That means there is dormant TB infection. They are dormant with no active symptoms or signs. Okay. How can I detect the latent TB infection? See, if I come with cough, with expectoration, you will ask me to get the sputum cytology done, or you will ask me to get the gene expert done on the sputum. That will detect that I have the MTB infection. Okay. But now, right, I might be having the TB bacilli in me, but how will you detect? Like I have that, let us say I have that TB bacilli in me, I have latent infection. How will you detect? Because I do not have any symptoms, right? So it can be detected by what? Common test. What do we do? Right? It can be detected by either main-2 test or the TB quantiferon gold test, which is an IGRA, interferon gamma release assay. Man-2 test, the utility is debatable in country like India, where almost everyone is exposed. So it may not be a very reliable investigation, and in countries where BCG vaccination is standard, Man2 will be falsely positive. We should be aware about it, but for the exam, you can write can be detected by either Man2 test or IGRA. IGRA refers to interferon gamma release assay. One of the commonly performed interferon gamma release assay is going to be TB quantiferon gold. TB quantiferon gold. Okay. So then that is our latent TB infection or LTBI, where there is TB infection, but patient does not have any signs of disease activity presenting with symptoms. Okay. So then we have active TB, where patient will have the signs and symptoms of an active ongoing TB infection. It could be pulmonary, or it could be extrapulmonary, or it could be miliary, which is a disseminated form, right? Extrapulmonary or miliary. Okay. Now coming to the other term that the question has asked us to elaborate on, that is MDR and XDR TB. Collectively, we can put it under the heading of drug-resistant TB. Drug-resistant TB. Okay. Now, drug-resistant TB means what? Drug-resistant TB refers to resistance to one or more of the first-line agents. What are our first-line agents? The rifampicin, ethambutol, pyrazinamide, isoniazid, right? These are considered as first-line agents. So, a patient has resistance to any one of those drugs or more than one drug. So, we will call it as drug-resistant TB. Now, what is precisely MDR TB? MDR TB refers to resistance to rifampicin and isoniazid. Rifampicin and isoniazid. So, if a patient is having rifampicin resistance and isoniazid resistance, it is MDR TB. Okay, then what is XDR TB? XDR TB refers to resistance to MDR plus some additional resistance. Then we will call it as extended drug resistance or extensively drug resistant TB. So extensively drug resistant TB will include rifampicin and isoniazid, which was part of our MDR TB. But in addition to that, fluoroquinolones. What fluoroquinolones are usually used for the TB treatment? Levofloxacin, right? Moxifloxacin, which have higher concentrations in the respiratory system, resistance to them, right? And at least one of the second line injectable drugs. Second line injectable drugs. They are mainly from the aminoglycoside group. So if one of the injectable second line agent is also resistant, then we will call it as extensively drug resistant TB. That means MDR plus fluoroquinolone plus one of the injectable second line agent. Then it is extensively drug resistant TB. Clear? Now, how do I make a diagnosis of TB? First thing is suspicion. Without suspicion, diagnosis of TB is not complete. So when do I suspect? Suspect TB in any patient presenting with cough for more than 2 weeks. This is our Indian guideline. Anyone with a cough of more than 2 weeks in India, we should suspect tuberculosis. Apart from that, anyone with unexplained fever or weight loss, we should suspect tuberculosis. Now, once you have suspected, how will I investigate and confirm the diagnosis? So investigations, there are n number of investigations available, right? So we have microbiological tests. Imaging can give us a clue or direction towards the diagnosis. We can do tissue biopsy. We can do other tests as well, right? So in terms of microbiological tests, most commonly followed test is sputum, right? So sputum smear can be done for AFB, but the detection rate is low and it is only useful for the pulmonary TB, not useful for extrapulmonary TB, right? What else I can do as microbiological test? Today we do a adapted form of PCR or CBNet called as Gene Expert MTB RIF. So what it stands for? It is a PCR, just like the PCR that we do for HIV, just like the PCR that we do for COVID. It is the PCR which detects the tubercle bacilli genetic material or the DNA of the TB bacilli. So if I am detecting the DNA in the sample of a TB bacilli, that means patient has TB infection, right? This is highly more sensitive than the sputum for the AFB. The added advantage is that we can also not just detect the TB genetic material, but we can also detect the gene for the rifampicin resistance. So in one go, I'm establishing the diagnosis of TB. At the same time, I'm also getting to know whether patient has rifampicin resistance or not. Because if he has rifampicin resistance, he may be belonging to one of these, right? He may be MDR TB, just the drug resistant TB, or even XDR TB. So I have to modify or modulate my strategies for medications. If patient is rifampicin sensitive, then I can go ahead with the standard initial treatment. Okay. Then we have one more investigation which is called as line probe assay or LPA, that can also be performed. Line probe assay or LPA. Okay. Then culture. TB bacilli are not easy to culture, but nonetheless we need to write it in the exam. Culture wise, there's a solid media, that is LJ media, and we also have a MGIT tube method for the liquid cultures. Okay. We don't need to elaborate on the microbiology side of it in a medicine paper. As long as you mention the names, it's more than enough. Okay. So that is microbiological tests. We also have imaging. Imaging, of course, chest X-rays for pulmonary TB. For extra-pulmonary TB, mostly we have to go for CT or MRI. So on the chest X-ray, what findings I will expect if it is the pulmonary TB. Pulmonary TB, as we know, predominantly affects the upper lobes, that to mainly the right upper lobe. So on the chest X-ray, in the right upper lobe, I may be seeing tubercular consolidation or opacification, tubercular consolidation, or I may be seeing cavitatory lesion because TB causes cavitation, or I may be seeing, I will, in addition to that, I will see hilar lymphadenopathy, lymph nodes being enlarged, hilar lymphadenopathy. And in more advanced cases, I can see miliary mottling. What do I mean by that? The whole X-ray looks like there are tiny dot kind of opacities extensively distributed on the chest. We will call it as miliary mottling, which is suggestive of miliary TB, right? So this tubercular consolidation and cavitatory lesions are typically more common in the upper lobe, right? That too mainly the right upper lobe. And then miliary mottling, as I told you, is suggestive of miliary TB, suggestive of miliary TB. CT or MRI is performed for the extrapulmonary TB. Like, just to give you an example, if I'm suspecting tubercular meningitis, what findings I will expect? I can get something called as basal exudates. Basal exudates in tubercular meningitis. Similarly, if I'm suspecting the spinal tuberculosis, I can see a tubercular abscess affecting the spine, and then I will label it as spot. Okay. What biopsy will show? Biopsies will show caseating granulomas, and biopsies may be positive for AFP, right? Biopsies may be positive for the AFP. What other tests are useful? I can do adenosine deaminase levels in fluids. For example, increased ADA levels in pleural fluid is suggestive of pleural TB. Similarly, increased ADA levels in CSF is suggestive of TB meningitis. So that is an additional test that we can do. So this is the investigations that we will be following for the tuberculosis. Okay. Once I have established that patient has got tuberculosis, how will I manage? So the management of TB, of course, depends on whether it is latent TB or it is active TB. Latent TB is where there are dormant tubercle bacilli in the body, no ongoing active disease. What is the goal here? There's no ongoing active disease, right? The goal is latent should not get reactivated to active TB. So the goal of treatment of latent TB is to prevent tuberculosis reactivation. On the other hand, active TB, of course, it is eradication or cure from the ongoing tubercle infection. Okay. So for latent TB, we just discussed about it when we were talking about HIV, that all Indian patients with HIV, the NACO recommends that they should be receiving INH prophylaxis for the treatment of or eradication of the latent TB infection. So if there is latent TB infection, we should be treating them with INH daily for 6 months. 6 months or rifampicin daily for 4 months. There are also other more costly regimens using rifampicin and all. But in India, we mostly follow INH. This is the preferred regimen that we follow in India. Alternatively, we can consider giving them rifampicin. Okay. Now, if there is active TB, which is not drug resistant, our standard first line treatment is using the INH, rifampicin, isoniazid, and ethambutol for a period of 6 months. In that 6 months, first 2 months we will give 4 drugs, that is HRZE, and the remaining 4 months we will give 3 drugs, which is HRE. That is our standard initial treatment. But if any point before or during the treatment, if we get to know that it is MDR or XDR TB, we need to revise our medications. So if it is XDR TB, if it is MDR TB, we will consider a regimen containing bedaquiline, linezolid, quinolones like levofloxacin, cycloserine, and clofazimine. And these medications now 6 months is not enough. Okay, again 6 months. When I say standard treatment, it is for pulmonary TB. If it is extra pulmonary TB, it requires longer duration. It depends, varies from organ to organ. For example, if I'm dealing with tubercular meningitis, it is 9 months to 12 months. So for pulmonary TB, it is 6 months. Extra pulmonary depends on the organ affected. Okay. Now, if I have XDR TB, extensively drug resistant TB, then today what is recommended is based on the culture pattern, right? To which drugs this particular bacilli is sensitive and to which it is not. We create individualized regimens and we try to utilize more modern drugs to which the resistance is still not documented or it is not very common. What are those drugs? We have drugs like pritomanid and delamanid. Pritomanid and delamanid. Okay, so in this answer, when examiner peeps his eyes into the answers and he is looking at the drugs that you mentioned, what he will be particularly looking for, he wants to see bedaquiline in your answer, he wants to see pritomanid and delamanid in his answer. So make sure that these are highlighted to the examiner's eyes. Okay, so that's about our TB infection. Okay. In HIV, we forgot to discuss one important complication. We will address that before we go to the next question on infectious diseases. So examiners may ask you to elaborate or write a short note on IRIS. What IRIS stands for? IRIS stands for immune reconstitution. Immune reconstitution inflammatory syndrome. So what does that mean? So when we have HIV, as our CD4 count goes very low and the viral load goes very high, our immune system is at its weakest, right? So when an infection comes, we are not mounting an immune response against it. So normally when I have an infection, I get fever, right? I get rash, I get swelling. What does that indicate? Our immune system is responding to the infection. That's why we have all these inflammatory symptoms. But if immune system does not respond to the infection, you will not develop the inflammatory symptoms at all, even when infection is actively going on in the body. Just to give you an example, right? Let us say there is a patient with TB meningitis, HIV, CD4 count very low, he gets TB meningitis. He may not get headache, he may not get fever, he may not even get neck stiffness because there is insufficient immune response from the body. So there is no inflammation of the meninges, only infection. So then he will not have the signs of meningitis, right? Now for such a patient, let us say I started him treating, I started him on the ART. Now the ART will take care of the virus, the CD4 count will start increasing. So immune response becomes stronger. Now suddenly our immune system realizes that, oh, there is an ongoing infection there. So let us all mount an inflammatory response. So this inflammatory response will be more exaggerated now to that level of infection we have. And then suddenly patient will start developing the signs of meningitis, right? So there is a rapid onset neck stiffness, fever, and there will be development of severe cerebral edema. Patient can have raised intracranial tension, and this may even lead to death of the individual, right? So what is this IRIS? It refers to Aniket. Okay, so if you are asking me what is the clinical book for bedside, okay, so there are plenty of books, all are good. I would personally recommend that for the examination methods, always Hutchison or MacLeod you should have for the right examination method. But for answering the Viva OSCE, I find in the recent times it is Archit Balur, which is quite good. Okay, so IRIS. What is IRIS? IRIS refers to either exaggerated inflammatory response to infections which was previously suppressed, due to immunodeficiency. And when is this happening? This is happening upon starting ART. So upon starting ART, Patients will have an exaggerated inflammatory response to infections which was previously suppressed due to immunodeficiency. We will call it as IRIS. Immune reconstitution inflammatory syndrome means immune system got reconstituted, now it is strong, it is giving inflammatory response. So what it manifests with, features wise, it can manifest with either appearance of signs and symptoms of infections which were previously covert. What do I mean by covert? That means previously they were not obvious or evident, previously covert, or previously some symptoms were there, some degree of immune response was there, now it is becoming worsened, right? Or it can present as worsening of signs and symptoms of infections. Okay, how do we treat? So first thing is prevention. Prevention by initiating ART after adequate treatment of opportunistic infection. So if patient already has opportunistic infection, first treat the infection and then bring in the ART, so that the infection is taken care, so that your body won't mount an exaggerated inflammatory response. And if it happens, right, then we can try to add corticosteroids to suppress inflammatory response, So that is about our IRIS. Okay, so now we will move to the third question for the day. That will be our last question. There are two more important questions that I would urge you to read from the Farre section on the PW MedEd app, which is on malaria and dengue. Okay. So the third question is on the enteric fever. Usually enteric fever question is 5 marks, or sometimes they will ask it as 10 marks, but in that case they will also ask you to write about approach to a patient with fever or complications of the enteric fever, or talk about the emerging drug resistance trends in India or something like that. Otherwise, enteric fever per se is a 5-mark question. So if they're asking a 5-mark question, the clinical features will carry 1 to 2 marks, diagnosis will carry 1 to 2 marks, and management will carry 2 marks. Okay. So what is enteric fever? Enteric fever is an acute to subacute infection with a propensity for chronicity. Means not all individuals will have only acute infection. Some of them become chronic carriers. So it is an acute to subacute infection with a propensity or risk for chronicity. You might have heard about the case of typhoid Mary, right? Some people will be carriers who can infect a large set of population as well. Okay. What is the causative organism? The causative organism is Salmonella enterica. Salmonella enterica via typhi and paratyphi. What is the route of transmission? The route of transmission of enteric fever is feco-oral route, right? Feco-oral route. That means patients who are infected with enteric fever continue to excrete the Salmonella bacilli in the stool, and that stool, when it contaminates the water reservoirs, can go and infect others as well. So feco-oral route is the mode of transmission. So when someone acquires enteric fever, what clinical features they will present with? For first 5 to 20 days, they may not have any symptoms because that is the incubation period, 5 to 20 days. After that, the symptoms start appearing, and there is a week-wise progression. There is a stepwise progression. So in the first week of infection, mostly patients develop fever, fatigue, and abdominal pain. Fever, fatigue, and abdominal pain. And in the first week, that fever that we described, classically it used to be described as step ladder, which is no longer seen in clinical practice, but once upon a time it was step ladder pattern, where daily progressively fever goes on increasing. It does not reach the baseline at all, right? Whatever it is today, tomorrow spikes will be much taller, next day spikes will be much taller without reaching the baseline. We used to call it as step ladder pattern. We don't see it today because even before coming to the hospital, patient or patient family members tend to give them antipyretics, either paracetamol or ibuprofen, which breaks this usual pattern, right? So fever is usually high grade fever that these patients present with. It is high grade, and you can write, for the sake of exam, it may show what we call as step ladder pattern. Step ladder pattern. Okay, if this patient develop abdominal pain, it is going to be relatively mild. These are the usual symptoms because the enteric fever, it's called enteric fever because the primary site of infection is the GIT, mainly the terminal ileum, right? Ileitis is what it causes, and then it becomes a systemic infection from there. So that's why they can have abdominal pain, fever, and fatigue. But as the condition progresses to the second week, we'll start seeing other features. In the first week, once upon a time, we used to have a diagnostic clue of what is called as Fagett sign. So what is this Fagett sign? Fagett sign refers to relative bradycardia. Now, what do I mean by that? Generally, when body temperature increases, there will be proportionate increase in the heart rate, right? Whenever we have fever, we have tachycardia. But in patients with typhoid and also some other infections like the Q fever and all, proportionate increase in the heart rate doesn't happen. Either heart rate doesn't increase at all or increase may not be as much expected for that degree of body temperature or the fever. There is relative bradycardia. The sign is not specific for enteric fever, but in India it used to be the most common cause for relative bradycardia used to be enteric fever. Okay, so these are all things that we see in the first week. As we progress to second week, patients start developing rose spots, right? Tiny rashes on the body, rose spots. Okay, and then the abdominal pain during the second week starts becoming more severe, right? The intensity of the abdominal pain increases, it becomes moderate to severe, and in the second week the spleen and liver may become palpable. Okay, so first week main thing you have to write is fever and relative bradycardia. Second week you have to write about the rose spots and hepatosplenomegaly. Okay, majority of the patients, even untreated, may recover with our own immune system's effort in 1 or 2 weeks. But some people, treated or untreated, may progress to third week with the illness. In the third week, those who are affected with severe enteric fever may develop CNS manifestations in the form of delirium or confusions. And at this point of time, patients are also at risk of intestinal perforation because whatever enteric bacilli that were proliferating in the Peyer's patches of the terminal ileum, they may cause severe inflammation and there can be perforation. So the usual site of perforation or the most common site of intestinal perforation is going to be terminal ileum. Terminal ileum. In fact, I remember a case where there was a patient hospitalized with abdominal pain. Fever was not mentioned in the complaints, and when she was hospitalized, extensive investigations were being carried out for the diagnosis of cause for abdominal pain, including they had suspected appendicitis, they had suspected mesenteric vascular insufficiency, they had suspected the duodenal or peptic ulcers, and they were planning for further investigation. And then suddenly her abdominal pain started worsening and BP dropped. And when an erector abdominal X-ray was done, there was gas under the diaphragm, indicating that there was a bowel perforation. So she was immediately taken to OT. And in the OT, the surgeon noticed that the site of perforation is the terminal ileum. So then, of course, the suspicion of enteric fever arose because of the acute nature of the illness. And the cultures confirmed that she had enteric fever. Okay. So third week, there's high risk of perforation as well. Okay. So when I am suspecting someone as having enteric fever, how will I make the diagnosis? Most of you will write Vidal test. Most of the doctors prescribe Vidal test, and Vidal test has become such an abused investigation that all those quacks and those alternate medicine practitioners today, anyone with the first day, second day of fever, they ask for a Vidal test, and once it comes with some titer, the report will come as positive, and they will call it as enteric fever. Start giving antibiotics left, right, center. And I would count that Vidal test is the most abused investigation, especially by quacks and the non-modern medicine doctors. But Vidal test is not the investigation of choice for enteric fever. It will not detect enteric fever in the first week, right? So what is the investigation of choice for the first week? The investigation of choice for the first week is going to be blood culture. Blood culture is considered as the gold standard. It will be positive in anywhere between 50 to 70% of the patients if culture is collected properly. Ideally, culture should be collected during the episodes of fever, right? And for blood culture, the culture media that we are going to use so that salmonella can be grown is either McConkey agar or Wilson Blair bismuth sulfate agar. Okay. In the second week, we can go for the viral test. By that time, antibody production would have started. Now we can detect the antibodies. So we are detecting antibodies which are agglutinins against H and O antigens of the cell in the second. The point to note here is there is no standard titer to say that, sir, if the titer is more than this, it is enteric fever. The titer varies from region to region depending on the endemicity. Right, in some regions the enteric fever is very common. So in that region, the general population will have higher titer. So titer above that threshold should be considered as positive. So just don't make a diagnosis of enteric fever just because viral report said 1 is to 80 or 1 is to 160. Don't jump and make a diagnosis of type 1. Clear? So you should be aware of the locally relevant titer to make use of viral test. And even better is that if you can serially monitor the viral titers, and if these titers are serially increasing, that is more diagnostic of enteric fever. So if you're doing it in the first week, ideally what you should do is do it on day 1 and do it on day 5. If the titer is increasing, then you can say, sir, this is a case of viral. Otherwise, it is the blood culture that is the go-to investigation for type 1. Right? So you can make a note to please the examiner, serially rising viral titers are more specific or are diagnostic of enteric fever rather than high titer. Okay. Once I have established the diagnosis of enteric fever, so remember in the third and fourth week, I can also do stool culture for the diagnosis of enteric fever. And for chronic carrier patients, I can also do the gallbladder biopsy or gallbladder aspirate culture, because gallbladder becomes a site of shelter for the organism in chronic carriers. Okay, so that's about investigation. So once I've established the diagnosis of enteric fever, how will I manage? Okay, so when it comes to management of enteric fever, those patients who just have simple fever and no other complications are encountered, we can try to treat them with more simple antibiotics like the Ceftriaxone, which is cotrimoxazole, or azithromycin. Right? If you ask me what is the drug of choice, I would write azithromycin today. Cotrimoxazole is not that commonly used, but the sensitivity of cotrimoxazole is increasing in the recent times because for a very long period we have not used cotrimoxazole or even other older antibiotics like chloramphenicol. We have not used them in last 15-20 years for enteric fever. So sensitivity is back. So we can consider using them. But for complicated cases like those who had bubble perforation or hypotension, for them we can consider using third generation cephalosporins. So most of us end up using ceftriaxone to treat enteric fever, and most of the quacks would start ceftriaxone even before they know that it is enteric fever. There is fever, they start ceftriaxone. So there is a rising concern that in near future the ceftriaxone resistance will catapult, and then maybe we will start looking for much more higher antibiotics, maybe fourth generation cephalosporins or carbapenems. So as of now, for the answers, third generation cephalosporin will be our answer. Okay. So that's it on the infectious diseases. We have covered 3 today: HIV, enteric fever, and tuberculosis. The malaria and dengue are also equally important. I would suggest that because we have beautifully created the notes on the PW MedEd Farre section, you can cover from that section. So I will take a break for 15 minutes and then we will reconnect for the next session where we will talk about 2 or 3 important questions from the emergency. Till then, have a good time, guys. See. Let me see if I have left anything unaddressed. Okay, good. Dr. Prakash Saini, thanks for elaborating in words that would be easy for the students.